Why did Max invite a home birth midwife to the Regenerate conference? I have the same interests as you guys, decentralizing maternity care. And my whole talk is based around that topic. And as Cindy was talking about the different philosophies of care that she presented, I was just thinking, wow, she's just giving my talk, but from her perspective. So I'm about to show you what Cindy was talking about, but from the perspective of maternity care. While we get this set up, I'm Melanie Jackson, home birth midwife. I've been a home birth midwife for 16 years. My PhD is on birthing outside the system. 2 home birthed babies. Charlie's 11, Frida's 7. And yeah, I think we're not so dissimilar, you'll find. Even though the topic might not be quite in line with regenerative farming, it's well in line with decentralization. All right, beautiful. I think we've already done this. So I live in the Blue Mountains, New South Wales, on a 5-acre hobby farm. We keep goats, and you can see that one smiling. That's Clara. She's cutie. We keep chickens, worm farms, compost from our goats, and milk from our goats for our gardens and ourselves. And we've created a permaculture-style food forest system at our place over the property. That's the intention, mostly because we want to live outside, not permanently, but and encourage that for our children and get them to understand what real food is like and real life is like. We homeschool, so we have lots of opportunity to do that with our children. So they're with us most of the time, except for right now. They're at home. So we want to grow real food, mostly because the flavour is so much better, and that's because it is so much better. I get really sad when I eat tomatoes from the shop because I know what tomatoes really taste like, and it's not that. So yes, we are also self-employed, so we've decentralized our time. So we can work whenever we like, we can school whenever we like, we can birth wherever we like. And yeah, this is our life. So we are not so different, even though I'm going to talk about home birth. So, like you all, I'm here to call out the futility of mainstream systems of modern living, because we've all identified inherent flaws and the destructive nature of so much of it. And we've realized that mainstream systems don't always serve the collective good and the health of people, and there are competing interests. And this is no different in the world of birth, in pregnancy care, postnatal care of mothers. So today I'll be answering less about is home birth safe and more about is hospital birth dangerous? That's the question that's not asked. We're always asking, oh, can you give birth at home? Is that safe? Nobody says, oh, is it safe? Is it dangerous to go to hospital? Because we're told it's safe. So that's what I'm going to talk to today. And if this room represented the general public of childbearing women, 97% of you would go to hospital to have your babies. I already know that there's at least 3 families in here who has not have their babies at home, so we're disproportionately represented, but this is what the general public would do. So approximately 97% here in Australia would go to hospital, give birth, and they would tell you that that's important because birth can be complicated, things can go wrong, and so you need to have an expert in the room. Otherwise, you're putting yourself in danger because birth is dangerous. That's the overarching message. You could bleed too much, your baby could get stuck, you could have a huge tear that requires repairing, your baby could get stressed and you would need a cesarean section, it might get stuck and you need forceps or vacuum. There's so many things that can go wrong. So it makes sense to go to hospital to have your baby. This is the consensus. And in today's maternity care system, it's important that we're all frightened of birth. It's important that we fundamentally believe that it's dangerous, because in order to uphold the current maternity care system and the infrastructure that's been set in place, there's a social and cultural reliance on us living in fear. because we will keep presenting to the hospital to have our babies because they tell us that if you go there, that's where you'll be kept safe. If we're not fearful of birth, we won't act in that way, and that's not in the best interest of how the system is set up. So we must continue to live in fear. And all the hospitals, in the hospitals, that's where the experts are gathered. And so we've been told they're the experts, they're the authority, they know how to keep you safe. And if you have an interest in your safety, that's where you'll go. So we'll first have a look at this concept of birth as dangerous. And there are two philosophies that exist along a spectrum. And I call this the medicalization spectrum. And so the medicalization of something is the process by which non-medical events, non-medical things, become defined and treated as a medical problem. This is how medicine and doctors will take over certain things. You know, we're doing it with sexual dysfunction, we're doing it with fertility, we're doing it with all kinds of things. We start to define things as a problem, and that brings it under the purview of medical responsibility. They go, great, we've identified it, now we get to treat it for you. So physiological events or just human differences become redefined as pathological, and so then now we have permission to offer you a treatment. And so at one end of the spectrum, the least medical end of the spectrum, is the philosophy which believes that birth is just a physiological process. Our bodies are designed to do it, much like pooing and weeing and vomiting and having an orgasm and ejaculating and digesting. Birth is just another normal process that our body is capable of. It's an inbuilt physiological process that we don't usually need help with. When it's time to give birth, all of the hormonal processes that occur in our brain start to act on our body, and it activates the process of labour, and then the process unfolds and we have our babies. So for people with this physiological philosophy, there's an understanding that sometimes there can be a complication and a dysfunction in this process, the same as all other physiological processes. If you don't give it exactly what it needs, it won't function as it should. But same with birth, if it gets the basic ingredients required for physiology to unfold and for oxytocin flow to occur, then most likely than not, it will be uncomplicated. And it works just fine. But there is an acknowledgement that it doesn't always go to plan. But that shouldn't happen very often if we're nurturing the physiological process. So this philosophy, the physiological philosophy, is usually held by midwives or lay birth workers. And this belief about birth, if women have this belief, they will most likely choose to be under the care of a midwife or a lay birth worker. That philosophy aligns for them. And this exists along a spectrum. And so the other end of the spectrum is the more medical, the biomedical philosophy, where there's a belief that women's bodies are inherently flawed and that most of the time we don't have the capacity to give birth without some medical input. And so we need medical help to have our babies. And under this philosophy, because our bodies are inherently flawed and birth is fraught with danger, it can't be trusted. The process can't be trusted. It needs very close supervision, and medically minded people now have started inventing and creating lots of gadgets whose function it is to measure and monitor and detect pathological activities in our labours and in our bodies so that they know when to step in and save us from our dysfunctional birth process. And so professionals now then get expert training so that they're qualified to save us and qualify them to monitor and manage our births and our bodies and keep us safe from our failing bodily processes. Now, the thing is that many women also believe that their body is not capable, and so they don't trust the birth process. They don't trust that without supervision that everything will go okay, and so we willingly enter the hospital system, we willingly hire experts in the interest of keeping ourselves safe from the birthing process, from our own bodies. so that when our body fails, there's an expert there to save us and our babies. And so the most likely health professionals who hold this biomedical philosophy, traditionally we pin this on obstetricians, but increasingly midwives are being indoctrinated and groomed into this mindset. And unfortunately, midwives have also started to believe that the birth process is inherently flawed. And so again, women who appreciate this philosophy and do believe that birth is fundamentally dangerous will most likely hire a health professional who can rescue them from danger. So obviously these are two extreme ends, and it exists along a spectrum, but it makes the point of philosophy. And so if we pair this with the place of birth, you'll see that on the least medical side, women can choose things like free birth, which is just to give birth without any health professional. And then along the spectrum, home birth, all the way over to a private hospital with an obstetrician. So this is these are the care options that women are presented with here in Australia. And I encourage women to plot themselves on this medicalisation spectrum, and then that will really help them make decisions about who they want to be their care provider and where they want to give birth. If you want a normal birth without a lot of intervention, there's no point going to a hospital with a private obstetrician because they're going to favour high intervention births and medical management. So it's important that birth decisions are paired, philosophies are aligned, essentially. All right, so how did it happen? This situation I just described, when 97% of women will go to hospital to give birth, because that's the normal way now, is to go there. But it wasn't always this way, and the practice of obstetrics is relatively new. It's a new intervention, and obstetricians or doctors have only been attending births here in Australia for about 120 years. So prior to that, the care of women during pregnancy and childbirth and postpartum was the domain of wise medicine women and midwives and community elders who were actually selected by the community to be in this role. It was considered prestigious. It was a role that was nurtured, and so the elderly midwives would select other women in the community to train and educate in the ways of attending women at birth. And so they were apprenticed over years and years and years, and knowledge was gathered and passed down in that way. That was how midwifery was done. That was how birth was done. There was no such thing as hospitals. The women knew that this was the domain of other women. So when you went into labour, I don't think a bell was rung, but there was some kind of indication that the women were to come in with this birthing woman. The wise women, the medicine women, the apprentice would gather in the home or in a sacred birthing space. There's lots of traditional knowledge about birthing trees and birthing caves and how important that is for connectivity to land and culture. And so this is how it was done. And the men went usually to find supplies, keep the house warm, make sure there was food, make sure that the new mother would be well nourished. And so it was a big community event. This is how it was done. And the historical accounts, when you look at historical accounts of midwives, they were revered and honoured and respected. They weren't governed, they weren't owned by the government or employed by the government. They were community members chosen by the community in this role. And so here in Australia, the move from giving birth in that way in the home and moving it into hospital was motivated by two events. And it wasn't that they looked at the birth situation and went, whoa, there's a lot of women dying, a lot of babies dying, we've got to do something about this. It wasn't motivated by that observation. So the first event that impacted the move from home to hospital was the colonisation of Australia, which commenced with the European settlers commenced in 1788, and the end of World War I, 1920, when Australia had entered a profound phase of poverty. And the historical records suggest that there was a significant increase in doctor-managed births between the 1900s and 1940. But the middle-class women it was reported that the middle-class women who were attended by doctors ran a greater risk of infection than did the poorer women attended by midwives. So even early on, as the transition was occurring, there was records that this new way of doing things with doctors starting to impose upon birth wasn't really working as well as when the midwives were in charge. So at this time in Australia, like still between the 1900 and 1940, it was still the norm to be giving birth at home, but doctors started to enter into the home and become part of the birth process. And after World War I, around 1920, there was a trend towards hospital birth, but the reason wasn't to create a solution for the problem of birth complications. It was rather that poverty was rampant, the Depression was here, and so they introduced what was called laying in hospitals. And the idea, it was a public service to poorer women actually. And so due to unemployment and depression and poverty, there was increased overcrowding in the homes, poorer nutrition, there wasn't enough food, the hygiene was poor, and they just lacked basic necessities to keep themselves and their babies healthy. And so they created these lying in hospitals for the women to go there. The idea is that it would be a bit cleaner, they would have food, they could provide some supplies for the baby, maybe they could help these women with just improved sanitation and nutrition. But they were still seen as inferior in terms of a birth option. And so the wealthier members of society continued to employ midwives and doctors to keep coming to them. It was only the poorest of the poor that got to go to these lying-in hospitals. And around the 1950s at least, the wealthier women were still giving birth at home here in Australia. So not that long ago. But as poverty got worse, the middle class increasingly disappeared, and there were less numbers of women who could employ or, have a midwife at their birth. And so with the increasing number of poorer families, there was increasing number of women using these laying-in hospitals. And so at that time in Australia, GPs were starting to get trained in a really kind of, university way. There was formal education for them. And so then these laying-in hospitals presented an opportunity for midwives to do the same. So they started training midwives to assist women in births in these laying-in hospitals, and no longer were relying on the community midwives who'd gathered these skills and knowledge over time and who had passed that down. So very, very quickly, midwifery education became medicalized. It wasn't rooted in this profound knowledge of birth physiology. It was all approached with a biomedical mindset. And so the laying-in hospitals became staffed by these new nurse midwives who were kind of the handmaidens of the doctors. And so they were responsible for just fulfilling the wishes of the obstetric team and of the GPs. They weren't autonomous practitioners as they had been through the community. And so this led to the rise that these midwives became more prestigious. The hospital midwives were considered more prestigious because they had Western formal training. And remember, we were trying to establish a colony rooted in European principles. And so they were considered superior because they had this Western training, and there was less value over traditional knowledge and traditional medicines and skills. So as I said, the affluent continued to have their babies at home, but from about 1940 onwards, doctors had managed to use deceptive methods to discredit the work of midwives. They had a financial interest in pursuing the care of pregnant women because GPs were coming, they were being trained, and they thought, well, if I can become the family physician and start care of these families right from the beginning, from their pregnancy, then that family will build my client base over time. And then they started being family physician to as many people as they could. And so the growing GP trade took over, and as we saw about medicalisation, they sort of took ownership of birth as coming under the purview of GP care. So that's why they moved birth into hospitals. It wasn't because it was dangerous. There was a financial interest in gathering clients. There was poverty that they saw as there was social necessity to actually care for these women in a laying-in hospital, but they were never intended to be the place to give birth in order to save them from birth. So in 1972, there was a published claim that all babies in Australia were born in hospitals, but in 1982, 10 years later, there was a reported claim that up to about 5,000 had been born at home, and most of those were attended by midwives. So we're starting to see around the 1980s a resurgence and an interest in home birth and a new understanding of the role of midwives. And so this is how we ended up here, 97% people giving birth in hospital. So my question is, was it a good move? I think you probably know the answer. Has it made us safer and healthier to have moved birth into hospitals with medical supervision rather than being cared for by midwives in a home setting? Well, there was this paper written in 1933. So, you know, in the midst of the transition from home to hospital, it's released in The Lancet, which is still a fairly prestigious journal today. And so in the transition, people were having a look at the outcomes. They were asking, okay, how are we going? We move them into hospitals. Is it good? So this is a quote from the paper. It was called The Safety of Childbirth. And this is a quote. So, among the changes which have been taking place in obstetric practice during this century, one of the most important is the increased use of hospitals for delivery. In a recent paper, DeLee and Stadenhoff discussed whether these recent changes in practice of obstetrics have resulted in better welfare of mother and child, less loss of life, greater protection of health. They came to the depressing conclusion that the increased preference of hospital as a place of delivery seems not only not to have bettered results, but seems actually to have made them worse. And they cited this Aberdeen report, which was an important report that came out of New York at the time, which stated that there is a serious risk in the usual maternity ward, which is absent in the usual confinement at home. Ease of intervention and a false sense of security in hospital have contributed to the increase in the number of artificial deliveries, which bring with them an increased mortality risk. Premature and unnecessary intervention have also been alleged as the reason why maternal mortality, maternal deaths, are higher in the practice of doctors than in the practice of midwives. So in the transition, in the actual journey towards hospital, they had a look at it and doctors were saying, it's not really working. Like, we've moved them into hospitals, but more women are dying when we compare it to what happens when we look at what happens to midwives when they care for women at home. So this does show that the calling out of inherent risks of hospital birth is not a new thing. I'm not standing up here sort of going, hey, we've got something we've noticed. They noticed it in the transition, but they chose not to stop. They continued with the process towards hospital birth because they were invested financially, societally. This was, yes.
Melanie, could I just ask?
Yeah.
If there was an increase in cesareans as a result of more ladies going to hospital for birth?
Yes, there's definitely an increase in cesarean. And actually, I was going to show you heaps of stats at the moment. Australia currently sits at around 39% of births are by cesarean now. It's insanity. Yes.
Which is for the convenience of the doctors.
It's for lots of reasons. You'll see by my talk, it's not for the well-being of babies, for a whole lot of other reasons. Yes. Thanks for the question. Yeah. Okay, so let's see what's changed now in the modern age of obstetrics, and we'll compare, back in those days, they didn't fully understand infection risk either. So one of the big issues with the hospitals was that the doctors didn't have a good idea of hygiene, and so more women were getting infections versus when they were at home. We've kind of eliminated that problem, but as you'll see, created a whole new one with obstetric care. And the language that most people understand at this point in history is that they want to know the physical outcomes of mums and babies, like how many are dying, how many are seriously injured, how many cesareans, how much blood is lost. So there are so many safety measures and outcomes that we could measure. So as a midwife, I like to look at quality measures. So was that woman satisfied? Was she traumatized by her birth? Did she have a positive experience? How is the bond between the mother and baby and the family? We could talk. I am running a conference in August, which is basically filled 3 days full of answering those questions. So today I'm going to speak to the physical outcomes because I feel like they're most poignant. But what we do know is that today, 1 in 3 women will report their birth as traumatic, and 75% of them are not traumatized by what physically happened to them. They're traumatized by the experience that they had with their care provider. And so there's a growing movement around the term obstetric violence, and it's believed that at least 1 in 10 women are physically assaulted by their healthcare provider during their birth. And similarly, 1 in 10 showing signs of post-traumatic stress disorder after having given birth. So it's like they've been to war, and that's the statistics in hospital. That's not the statistics at home. So we could speak to that all day, but I'm going to speak to you on the physical elements. So this study I'm going to use is considered the most statistically authoritative paper here in Australia, and it mimicked a lot of what the smaller studies were already telling us. This kind of was the nail in the coffin of hospital births, I believe. This study was an Australian study. It was on women who had had uncomplicated pregnancies between 2000 and 2012. Single baby, head down presentation, so they weren't breached, and they were normal terms, so between 37 and 41 weeks. These women should do brilliantly in birth. There should be very few women who have a problem. It's the lowest of the lowest risk category that they looked at. So they looked at over 1 million births, 1,200,000 and some, and 93.6% of them gave birth in hospitals, 5.7% in birth centres. So if you don't know about those, sometimes a hospital has a birth centre either in their hospital or just slightly detached. So it comes under the hospital service, but it's not the usual maternity ward. And then 0.7% were born at home. Now, the results, I'm going to give you the baby's results first, just to get them out of the way. The results were that there was no statistically significant difference in the proportion of stillbirths, so babies who were born not breathing and who never breathed, and neonatal deaths. So that's in the first 28 days after birth. No difference. Regardless of where you give birth, if you choose home, birth centre, hospital, your baby will have the same outcomes. Very, very similar, no statistical significance. So all the babies did well, regardless of where they were born. It's good news in Australia. Babies have really high rates of survival and thriving after birth. But what nobody asks is, well, how were the mothers after this? And so how did they do? Let's have a look. So let's have a look at the likelihood of normal labour and birth. So this is a vaginal birth without caesarean, without vacuum and forceps. So for these women who give birth at home, and I'm a home birth midwife, I can attest this is approximately what my stats look like too. If you're low risk, 95.2% chance that you're going to have a normal birth without any issues staying at home with your midwife. If you move closer to the hospital, go to the birth centre, still not too bad, 89.2%. For this same group of women, low risk, no drama, not unhealthy, 78.6%, just by changing the birth location and the care provider's philosophy. So This tells you that in a circumstance where you're with a care provider who trusts the birth process, the physiological process, and who favours a less intervention birth, you're more likely to have a normal birth. So the question has to be asked, is there a problem with women's bodies, or is there a problem with how women are being and where women are being cared for? So let's have a look at bleeding. This is the other thing. When I get clients come to me thinking of planning a home birth, one of the questions is always, what will you do if I bleed? And so let's have a look. These are in 1,000 numbers. So here, the 5.3 women per 1,000 will have a bleed after giving birth greater than 1,000 mils, also requiring a blood transfusion. You'll see the rates are not dissimilar for a home birth. The difference is that at home, just like we wait for the baby to come out with as little interruption and intervention as possible, we wait for the placenta to come out with as little interruption and intervention as possible. And so then we get a rate of approximately 5.4 women in 1,000 will have a bleed big enough that requires them to have a blood transfusion. The stats are pretty much the same in hospital, but the difference is that every single placental birth in hospital is managed with medicine. So women will get an injection of oxytocin, artificial oxytocin. Then the clinician will cut the cord of the baby and extract the placenta by tracking it out of the woman. It happens within minutes of the baby being born. The reason they do that is there is some flawed research about if you intervene in this way in the placental birth, that you're going to reduce the rates of postpartum hemorrhage. I think what we can see here is that actually when you don't interrupt in the physiological process, it works the same way as if you do interrupt. The problem with this hospital stat is that having your placenta removed from you is not particularly comfortable. It also requires medicine. It requires a healthcare provider to be present. It requires plastic, a needle. There's waste. It seems to be unnecessary from what we're seeing here. So again, it just reiterates to women that you need us to help you in this process. If we weren't here, you would have bled because we wouldn't have had this intervention. But we can see that that's not true in this study. Labour, cesarean sections. So again, this rate's actually pretty low, but again, we're looking at super low risk women who should theoretically be able to have babies with very little intervention. So if you have your baby at home, your chances of a cesarean section is 2.4%. If you move closer to hospital, birth centre, 4%. If you go to hospital as a low-risk woman, your rate of cesarean will be 7.8. This study was done 2000 to 2014. The rates of cesarean section were significantly lower. They grow about 1 to 2% every year. So we're currently around 39% of women having cesarean sections. So I suspect that this 7.8% rate is going to have gone up since this study was done. Remembering, some people will say, well, yeah, they give cesarean sections, that's because it will stop babies from dying. It will keep them safer. But in this study, what we've seen is there was no difference. The midwives could achieve the same outcomes at home caring for women as the hospital could with a significantly less rate of intervention. So we're over-interfering in birth to no benefit of the babies, but to the detriment of women. So you don't do very well for quite some time after having a cesarean section. It's major abdominal surgery. People talk about, I had a cesarean. You had 3 to 4 major layers of your body cut open, including your uterus. It's not minor surgery, it's major surgery. And we're just giving them out like they're lollies at the moment to no benefit to the babies. So we have to ask who's benefiting from an increased cesarean section rate. It's not babies and it's not women. Forceps and vacuum, these are combined stats. Again, at home, 2% of women are going to require this. Birth centre, 6%. If you go to hospital as a low-risk woman, 1 in 10 will have forceps and vacuum applied to their baby. This is usually because there's a time limit to birth in hospital, and if you don't adhere to the time limit, they freak out and they do everything they possibly can to ensure that you comply with their time limit. So if you've been pushing for too long, if your labour's been too long, if the baby's sitting there too long, they'll just get it out with their methods. No improvement. It's not like they increased the vacuum and forceps rate and saved heaps more babies. It's the same, whether you do it or not. Augmentation. So again, we're going further down the rabbit hole of intervention here. So again, as I said about time limits, the hospital has a predetermined time limit that they would expect your labour to conform to. If you don't, they'll give you medicine to speed it up so it fits their definition of normal. If you were to have a home birth, you would be augmented 3.4% of the time. Birth centre, again, 16.5% of women in hospitals are low risk who have normal bodies had to succumb to this. And an induction is not risk-free. We know that if you have an induction, you increase your risk of fetal distress, of bleeding afterwards. There's an increased chance that you'll need pain relief because it's much more painful than physiological labour. So then you layer on the complications of things like epidurals. And so it's this, what we call this cascade of intervention occurs, where one intervention leads to a complication that needs to be remedied by another, by another, by another. Often the end point is vacuum, forceps, caesarean sections. So our bodies are not flawed, but the way that they're cared for have inherent flaws within them. That's not to say that being cared for by an obstetrician or a medicalised midwife in a hospital is wrong. You just have to know that you're exposing yourself to a new risk that doesn't exist in birth already, that you're now exposing yourselves to the iatrogenic risks that will be offered to you by medical intervention in birth. Let's see how many women, so when you give birth, occasionally you'll get a tear to your perineum, which is that space between your anus and vagina, for those who have them. So we all have a perineum. Actually, the guys do too. It's just unlikely to tear during childbirth. So if you're at home, half of the women will have a tear. You know, that area, that perineum, is part of our body that knows it's been designed to give birth, so it will stretch and open. Occasionally it will tear, but it's also capable of repair. So as a home birth midwife, I very, very rarely need to suture these types of tears. They'll actually sit together and heal very beautifully because that's what that part of the body was designed for, because that's where our babies come out. So if you give birth at home, 50% of the time you'll probably have some kind of perineal trauma, tear. Again, a little bit more likely to tear if you go to a birth centre. If you go to a hospital, the chance of your perineum being intact is 26%. So again, they were seeing a positive impact here from having stayed at home. And it's not, so any interventions that are occurring are not creating less damage for women. They seem to be creating more damage for women to no benefit of their babies. So the message is usually we're doing all this to keep you and your baby safe. So I'm asking, but are you? I don't know. Episiotomies, I'll speed up a bit here, but an episiotomy is a surgical cut to that perineum, to that area. If you look at the reasons why we would do an episiotomy, in the research, it basically says if you can see like this much of the baby's head, and the only reason it's not being born is that there's some tightness in the perineum and the baby's actually in distress and you need to get the baby out in order to help it, maybe there's a good reason to do an episiotomy. I've been a home birth midwife for 16 years and I've cut one in 16 years. There was only one time where I thought, I think this is probably the time in my career where this baby's going to benefit from being born faster. That baby was fine. We did do an episiotomy. So at home, chances are 2.6%. If you go to a birth centre, 8.3% of the time your perineum will cut. If you go to hospital, 17% of women are having their perineum cut in order to give birth. The national stat, overall is 25%. 1/4 of women are being cut at the point of being at full stretch, when the only reason why you really should be doing this is if the baby's in fetal distress. So either 25% of babies who are born in hospital are in significant distress at that point in birth, or the intervention of episiotomy is being significantly overused. And it's not like you can just recover from an episiotomy in the same way that you can recover from a tear. When a woman tears, she'll tear path of least resistance, not through major muscle bodies, not through major blood vessels. When you cut an episiotomy, it's through major pelvic floor muscles. And any woman in the room will tell you how important your pelvic floor is for lifelong health and how connected it is to all the other diaphragms and areas in your body. And so we have to ask what's happening to women's bodies, low-risk women's bodies, when 17% of them are being succumb to episiotomy. No change in the outcomes for babies. So we're not improving outcomes for babies, we're worsening them for women. So the outcomes here have shown what previous home birth studies have shown, that if you plan a home birth accompanied by a midwife who has adequate access to the healthcare, outcomes for babies are at least the same as when you have a baby in hospital. But compared to hospital birth, the odds of a normal labour and birth were twice as high if you plan to give birth in a birth centre, 6 times as high if you plan to give birth at home. And so the research evidence is undoubtedly clear that home birth is significantly, without a shadow of a doubt, better for women in physical outcomes and equal to each other if you look at the outcomes for babies. And this is what the evidence has systematically shown us. So it's time to stop asking, are midwives and home birth safe? And start asking, is hospital birth and medical care dangerous? I'm happy. I don't know if I have time for questions. Thank you. Do we have any time for questions? Yeah, John?
Quick question.
Yeah.
Is there any association between hypertension post-birth and hospital birth?
Well, yeah.
Testing.
Oh, yes. So there is a question, is there any association with hypertension at post-birth and hospital birth? It's a bit of a loaded question because there's issues with, we've got lots of higher rates of pre-eclampsia at the moment it's generally poorer health of the population overall. The possibility of suddenly high blood pressure after any birth is fairly unlikely unless there was some underlying disease prior to the birth. It's unlikely to have been caused by birth itself. Yeah.
Perspective, Yep, sure. From an immunological perspective with C-section and how that differs from a vaginal birth, is there any techniques that are proving really successful in actually assisting the baby? Because when a baby is born vaginally, as I understand, they get gob full of the fluid, and that helps them really evolve a really good immune profile. Are there any techniques for C-section that are proving really successful in that place?
Yes. So the backstory is that when you're born vaginally, your initial microbiome that you initially adopt is whatever's inside your mother's vagina. There is a microbiome in the amniotic fluid they're starting to learn, and so there's a real benefit to being born vaginally. There used to be a thing, they've researched something called vaginal seeding. So if you suspect that the mother might need to have a cesarean section, you can moisten some sterile gauze and insert them in the vagina and kind of inoculate the gauze. And then when the baby's born, you kind of do a bit of a rinse over with the vaginal microbiome. It's important that that's done before antibiotics. So during a cesarean section, they'll give the mother IV antibiotics. So what they have actually discovered is there's an epigenetic difference between babies who are born by cesarean section than babies who are born vaginally. And there's a lot of research being done on how cesarean section changes our epigenetics, but also the mechanical importance of being pushed through the vaginal canal and the impact that it has on lung expansion and all that kind of stuff. So I don't know that there's a lot of interest in discovering how bad cesareans are for babies, unfortunately, except some boutique kind of studies. There's no way they're going to fund something that would challenge the authoritative knowledge around birth in that way, but definitely poorer outcomes long-term for babies who are born by cesarean section. There's some things that you can do to sort of try and regather that. And certainly the cesareans that are necessary, you kind of go, well, maybe that baby wasn't going to do so well without the cesarean section, so we'll accept some of the downsides because the baby's alive and well. But this, you have to seriously ask, are we making things worse for babies who didn't need a cesarean section? Yeah.
Okay, last question there at the front.
What do you do about the argument that there's the healthy user bias, so the people that home birth probably higher socioeconomic, more concerned about their health, and then the hospitals sort of have to pick up everyone?
Yes, great question. So this particular study was lower risk women who had generally the same health. There's definitely a tendency for my clients to be well educated and heavily invested in their health, where they'll willingly hand over $7,000 to me to be their private midwife, where there's a disenfranchised group who either can't afford that or don't know about that. It doesn't really explain, though, the differences in outcomes. You know, a person who is not as well educated or has less financial interest in birth still has a fundamental physiological process in their body that's not affected by their socioeconomic status. So birth should theoretically work, and it seems to be less about the woman's philosophy and social capacity and more about the downfalls of what they're being offered in hospital. Yeah, I guess that'd be a whole essay question to answer, but yes, there's an element of that, but it doesn't explain it fully. Yeah. Thank you.
Thanks, Mel.
Thanks.